Welcome to Concise Approach to Internal Medicine. My name is Guillermo García. I am an internal medicine physician, and today we will answer the question, what are the most appropriate drugs for thromboprophylaxis in hospitalized patients? First, it's important to know if the patient has a contraindication for the use of pharmacological thromboprophylaxis, and according to the previous answer, we will define what is the most appropriate therapeutic option for the patient. The absolute contraindications for thromboprophylaxis are acute bleeding from wounds, drains, or injuries, intracranial hemorrhage in the previous 24 hours, heparin-induced thrombocytopenia. It indicates the use of fondaparinux. Epidural anesthesia, spinal block within 12 hours of initiation of anticoagulation, use of warfarin, unfractionated heparin, low molecular weight heparin, or direct thrombin inhibitors. The relative contraindications are coagulopathy with an ENR greater than 1.5, intracranial lesion or neoplasia, severe thrombocytopenia with platelet count less than 50,000, intracranial hemorrhage in the last 6 months, or gastrointestinal or genitourinary hemorrhage in the last 6 months. If there is an absolute contraindication or several relative ones, therefore, the use of non-pharmacological prophylaxis should be considered, which can be performed with pneumatic compression stockings for intermittent use with a duration of 18 hours per day in a 4x4 scheme, 4 hours of mechanical compression and 4 hours of rest. If there are not contraindications, we could answer the question, what is the most appropriate therapeutic option for the patient? Among the most widely used medication is enoxaparin with a dose of 40 milligrams subcutaneously every 24 hours. In most critical and non-critical hospitalized patients, in surgical patients with moderate risk of thromboembolic disease, and in patients undergoing surgery for abdominal and pelvic cancer. The subcutaneous dose of enoxaparin, 30 milligrams every 12 hours, is indicated in patients with bariatric surgery, orthopedic surgery with prophylaxis for at least 10 days, and in patients with hip fracture surgery, total hip replacement, and total knee replacement considered continuing for up 1 month in high-risk patients. This dose also applies to patients with acute spinal cord trauma. Another low molecular weight heparin is dalteparin. The dose of 2,500 international units every 24 hours is indicated in the majority of medical patients and in abdominal surgery with moderate risk. In this situation, it should be administered for 5 to 10 days. The dose of dalteparin, 5,000 international units every 24 hours, is indicated in orthopedic surgery with prophylaxis for at least 10 days and in patients with hip fracture surgery, total hip replacement, and total knee replacement considered continuing for up 1 month in patients with high risk. Also in patients with high-risk abdominal surgery who are administered for 5 to 10 days, and it is considered to extend up to 4 weeks in surgery for pelvic abdominal cancer. Finally, this dose can also be used in hospitalized patients. Unfractionated heparin in doses of 5,000 international units every 12 hours is indicated in hospitalized patients with intermediate risk, such as gynecological surgery, in patients with epidural catheters, and patients with severe chronic kidney disease. The dose of unfractionated heparin 5,000 internationals every 8 hours is indicated in patients with high thromboembolic risk with low risk of bleeding, patients with urological or gynecological oncological surgery, and medical patients with high risk of thromboembolic disease. Fondaparinux at a dose of 2.5 milligrams every 24 hours is indicated in orthopedic surgery with prophylaxis for at least 10 days and in patients with hip fracture surgery, total hip replacement, and total knee replacement considered continuing for up to 1 month in patients with high risk. Regarding oral anticoagulants as rivaroxaban in a dose of 10 milligrams orally every day and apixaban 2.5 milligrams every 12 hours is used in patients with orthopedic surgery as total hip replacement for 35 days and total knee replacement for 12 days. The following is the bibliography used to answer the question. Thank you so much. Don't forget to subscribe, like the video, and share it.